I have a question for Dr. Youssry, if I may.
Yes,
So
Dr.
in the second case, your patient complained of constipation. Were you not hesitant about using erenumab in this patient who already has constipation? Did you consider other alternatives?
The issue is here, I spoke with her about this condition, but the issue is she already has a chronic migraine and she already has a medication overuse headache. So which to start? If I give her triptizol, she's already on fluoxetine. If I started propranolol, she already have an anxiety and depression. So to have constipation with migraine or to have all of these and to control her migraine. So I think here the decision was to address first her migraine, reduce the attack, and she's happy with the result that we reach. And her irritable bowel already she's following the psychiatrist and regarding this condition and the constipation. As I know, it's a long run side effect. We need the patient to use it for the Renomab for a long time. So we had this. Anyway, I informed about this side effect and we are following, hoping that it will not affect the decision of the medicine.
Yes, this is because other CGRP based therapy does not have a precaution, or none of them have precautions, but that doesn't have to worry about constipation. But I think you stated it correctly when you said you inform the patient, and if there is any worsening in constipation, then we can address that. In most patients, we will not see any worsening in constipation.
There is one question to Dr. Youssry. Would you consider changing fluoxetine to Mertazapine?
The issue is she is following with her psychiatrist. I spoke with him regarding other option that we can use, but he told me that the patient already settled for this for years and she's already happy with this medication. So I didn't interfere with the choice of the SSRI that she is on.
Okay. Mertazapine is very good medicine, but it's very sedating. It's used as depressive medicine and at the same time causes sedation. So sometimes it's good for people, and elderly people with dementia and who has underlying depression. Okay. One of the questions here, does brain tumor cause migraine? That's
I can answer that if you like. Brain tumors can cause headaches. The phenotype of the headache with a brain tumor may include nausea or vomiting, but once you have a brain tumor, whatever headache starts is a secondary headache, so you can no longer call it migraine. Are there cases out there of patients who were thought for many years to have migraines and then turned out to have a brain tumor? Well, yes, these are reported cases, but these people didn't have migraine from the beginning. They had a phenotype of migraine, but their diagnosis should have never been migraine.
Are people who are having cervical disc prone to get migraine?
I can answer this question. Yes, we have certain types of headache like migraine that can be triggered by a cervical disc or cervical disorder. It could be one of the causes that can trigger migraine.
So there's a big difference between cause and trigger. Cervical discs, to the best of my knowledge, are never a cause of migraine, but any pain in the neck from cervical disc or otherwise can help, as you said, Dr. Youssry, can help trigger a migraine attack.
Yes.
I see a lot of people with migraine undergoing MRI of the cervical spine, and I sometimes wonder why. There are things called cervicogenic headaches. Cervicogenic headaches are strictly unilateral, rarely bilateral. They have specific criteria. They're not migrainous-like usually. So, I see a lot of patients coming from primary care with X-rays of the cervical spine, with straightening of the cervical spine and this and that, and certain osteoporosis or whatever degenerative changes, and all of a sudden their migraines or headaches are attributed to this. Sadly, this is not the case. If you have neck pain, if you have degenerative cervical spine pain, yes, pain can trigger the migraine just by having neck pain and so forth, but it's never a cause. Migraine is a brain disorder. The cause is in the brain.
I read some study across by that 25% of migraineurs present with neck pain. So neck pain could be presentation of migraine in most cases.
I have a poster in my clinic, Abubaker. You've never been there, but I have a poster in my clinic that shows, you know, where the trigeminal nerve goes and connects, and it extends into the face, into the sinuses, into the forehead, to the eye, to the nose, and into the neck. And this, I think, just is a visual way of helping patients understand that sometimes when they start off with neck pain, that's the start of their migraine.
How effective are occipital nerve block and sphenopalatine ganglion block for people with migraine? I believe you answered this question, but maybe we should emphasize it again.
Yeah, I don't do sphenopalatine ganglion blocks, but I know you do. Maybe you want to address that.
Yeah, and this tell you my bias. I mean, many cases who tried many medicines and haven't improved, giving them a pulse course of sphenopalatine ganglion block over the course of 3 to 6 weeks. For most case scenario, I see some effect on it. My MIDA score are reduced in most of the patients by 50 to 60%. But it's time consuming. You need to bring the patient every 2 or 3 days to do the sphenopalatine ganglion block. And most of the time, the doctors, neither the patient have time to come to visit you. But I use them usually in acute phases every week. If it's not effective, then I use it every 2 or 3 days. And I have finger count patients whom are using sphenopalatine ganglion block on monthly basis now.
You know, it's easier for you to do it maybe in the government sector, because for me to get approval for this in the private sector is a nightmare. And that's part of the reason why I have been discouraged. Are most of your patients in the government sector or in your private clinic as well?
Most of them are in government, yes.
Yeah. Occipital nerve blocks are quite effective, especially for status migrainosus. This is where I find them to be most effective. I recently, one of our nurses on the ward, which kept complaining, and I just took her out into the nursing supervisor's room. I put her in the chair and I gave her bilateral occipital nerve blocks, and it broke her cycle. And I think it's something that the ER physicians need to also. It's very easy to administer. It's really something that can be very helpful in status migrainosus when nothing else seems to work.
This question is to Dr. Youssry. How about using Cymbalta or Effexor in people with migraine and comorbid depression?
It will be a secondary treatment, but it will not be a regular, the first line of treatment, Cymbalta and Effexor, it is not level A to start with as a treatment for migraine. So we can use it, but to add as add-on therapy for her migraine, and the primary therapy for her associated condition. Effexor, yes, is known as a level. We can use it as if we have a migraine and a comorbid depression, but to depend on from the beginning, I think it will need to be case by case, but we cannot make it as a rule.
Dr. Kayed, any opinion?
I think Dr. Youssry and I and you are so very lucky that we now have the CGRP-based therapies that we can make statements like this. I mean, if somebody asked us this question 3 years ago with no CGRP-based therapies, then we would jump on things like the SNRIs, like duloxetine and venlafaxine and so forth, because we didn't have anything better. You know, it was part of the oral medications. But now, because we have these CGRP-based therapies, which are much more effective with less side effects, then we go for that first. Now, of course, we still need to treat the underlying anxiety or depression or whatever it is, and we may still utilize these medications, but it will be for the anxiety and depression rather than for the migraines.
As you mentioned, Dr. Kayed, anxiety and depression could be one of the symptoms or pre-monitory symptoms prior to the headache. So if this is the situation, then probably CGRP antagonists or preventive medication would alleviate these symptoms. You touched on this, Dr. Kayed. Does chocolate and caffeine induce migraine headache? Maybe you need to reemphasize it again.
Okay, so two different things. Chocolate also has caffeine in it. I should next time I will include the caffeine content of chocolate, not white chocolate. White chocolate is just sugar. So in some people, but let's talk about caffeine first of all. Caffeine usually does not trigger migraines, at least in my experience and in the literature. It's usually caffeine withdrawal that triggers a withdrawal headache that may trigger a migraine. So that's as far as caffeine. And therefore, I don't tell people to stop caffeine. I tell them 1 to 2 units of caffeine a day is acceptable. Going with what I mentioned earlier, less than 200 milligrams per day. When it comes to chocolate, it's basically only about 30%, 3 out of 10 patients with migraine have a food trigger. Only about 30% have a food trigger. That means 70% don't. So I tell my patients, do look for a food trigger, but if you don't find one, don't be surprised. And now looking for a food trigger is not easy to do because we eat out and we have foods that have many different ingredients in it. But you know, we do know what that some people are sensitive to these things. And then the other issue comes, is it a craving for chocolate? Yeah, that is part of the migraine as a premonitory symptom, or is it actually a trigger? And some people, like Professor Peter Goadsby, is very, very highly thinks that this is a premonitory symptom, whereas other people still think it's a trigger. So there's no black and white answer here, but these are the situations we deal with. And we just tell patients, you have to be a good detective. I can just tell you about these things. You have to watch. You know, life is difficult as it is, with or without migraine. You don't need to make it much more difficult by imposing unnecessary dietary restrictions. So look into it. If you find truly that it's a trigger, you know, you can test yourself over many days and weeks and months. If you find truly that it's a trigger, stop eating chocolate for 2 months and see what happens. I mean, if you can't stop eating chocolate for 2 months, then you've got a problem. You can stop anything for 2 months, right? Stop it and then see what happens. And if there's absolutely no change in your migraine, then you know it's got nothing to do with it. And if suddenly you have a big change in your migraine, then you know that perhaps this was a contributing factor, and then you can make the decision whether to go back to it or not.
One of the questions for caffeine withdrawal headache or migraine during Ramadan, what's the best prophylactic medication in your opinion?
A cup of coffee at suhoor, right? Isn't that what we said? A cup of coffee at suhoor reduces the chance of caffeine withdrawal, or even before Ramadan starts, start bringing down the number of cups of coffee and tea and caffeinated beverages that you have. I usually tell patients who come to me, I frequently have patients who are consuming maybe 8 cups of coffee a day. And I say, okay, this is regardless of Ramadan. I say, okay, for 1 week, make it 7 cups of coffee a day. And if you have to have the 8th, make sure it's decaf. So do it by weekly intervals, because we don't need to precipitate caffeine withdrawal. And if you do it in weekly intervals, it should not be a problem at all. Some people can do it faster. My advice is, before Ramadan starts, start slowly bringing down your caffeine intake. If it's a problem for you, then at suhoor you have one. Now, if you eat suhoor and go to sleep, it's going to be difficult if you chug a cup of coffee and try to go to sleep. So maybe that's not the best option for you. And I know, actually, I have a friend of mine who does not fast, or used to not fast, because he just couldn't stop drinking coffee. Now that's between him and his God. Yeah.
Okay, does much happiness cause migraine headache?
So the brain of migraineurs is sensitive to change, good change and bad change. So an overexpression of emotion, whether good emotion or bad emotion, can make you more vulnerable to headaches. So I don't know of any specific studies mentioning this, but it can potentially be a trigger. But if I had to choose about overly happy or not happy, I would go with overly happy and deal with the migraines. We got good medications for them.
One of the audience asking, I have migraine headache, but I get different type of headache during fasting. Would the treatment be safe?
So I don't know what she means, he or she means. You know, the fasting headache is usually a bland tension-like headache. But if you have underlying migraines, the headache from fasting could still be a tension-like headache, or the fasting could actually trigger your migraine headache. So you just have to use whatever medication is specific for that headache phenotype. So if you think it's a tension type headache, then maybe you want to take a diclofenac suppository. If this is happening only in the beginning of Ramadan while your brain starts to get used to this new pattern of eating and sleeping, then maybe taking etoricoxib at suhoor may be useful. If you think it's a migraine-like headache, then maybe still diclofenac suppositories might work, but you also may choose subcutaneous sumatriptan, possibly.
One of the questionnaires, can you use COX inhibitor every day during Ramadan for 30 days?
You're not going to get medication overuse headache from using it every day. So yes, you can use it every day as long as you don't have a contraindication, a GI contraindication. But remember, in that study from Palestine, it was only effective in the first 6 days. So you could see a benefit on day one of Ramadan, and day 1 through 6. But in the second week of Ramadan, there was not much a difference between placebo and etoricoxib. So I'm not so sure if there will be a benefit from continued use.
I mean, if you go with the medication overuse headache types, COX inhibitor is one of them, right?
It is,
So
but you know, the definition of medication overuse headache is a change in the character of the headache, and you have to use the medications on, well, if it's simple analgesics, on 15 or more days a month for at least 3 months. So Ramadan is 1 month, so that should not be an issue if you don't have medication overuse headache before.
So if you treat my status migrainosus with the cocktail of medication along with IV fluids, would that be breaking fasting?
I believe IV fluids would be breaking fasting, right?
That's probably part of the treatment. We need
then you'll break
need
the
a
fast.
religious guidance here.
No, but it said from the fatwa, right? If you're taking something for like IV fluids, I believe the way I understood that fatwa would break the fast, yes. And if you're having lots of nausea and vomiting and you're dehydrated, then that day you're not going to be fasting. You're going to have to make it up some other time.
And one of the audience is asking, where is your clinic?
In Dubai.
Both of you. Youssry, Dr. Youssry. Dubai as well?
Dubai as well.
Okay, I think we concluded all the questions, most of the important questions. And it's now 9:15. If no one has any urgent burning questions, I think we're going to conclude the talk. And thank you very much, Dr. Deeb and Dr. Youssry, for your interesting talk. We had a fruitful evening with headache, day 2, and we can now manage headache during Ramadan easily, inshallah. Thank you very much, everyone, for attending this session, and thanks the organizers for organizing this. Thank you very much.
Thank you.
Thank you for hosting us. Good night.
Thank you. Good night.
Thank you very much, Doctor.